Hello guys, hope you are all okay. You are all enjoying your life and welcome back to Ultrasound Teaching Videos with Dr. Arshad Nadeem Awan. Today my topic of discussion is endometrial cancer. Endometrial cancer is one of the common cancer, can be seen worldwide, but mostly in North America it is very common. The patient who's suffering from endometrial carcinoma will present with endometrial uterine bleeding, abnormal uterine bleeding. This could be during the menstrual cycle, which is called as menorrhagia, or this could be without menstrual cycle, that is termed as metrorrhagia. So menorrhagia and metrorrhagia, both conditions can be seen in endometrial carcinoma. Beside these features, if the patient is on HRT, those who are taking hormonal replacement therapy, they are also prone to developing endometrial carcinoma, especially those ladies who are on unopposed estrogenic replacement therapy. And unopposed estrogen is usually is very common for the developing of endometrial carcinoma. Those who are taking tamoxifen for the breast cancer, because tamoxifen contain estrogen, so this excess of estrogen also lead to endometrial carcinoma. If there is hyperplasia, atypical hyperplasia, there are in the previous videos I have explained that endometrial hyperplasia could be cystic hyperplasia, could be adenomatide hyperplasia. These two are the typical features in which the chances of the cancers is very low. But if there is atypical hyperplasia, which does not fall in the category of either cystic or adenomatide, so there will be a great chance of developing endometrial carcinoma in endometrial hyperplasia. These are the factors which are responsible for the developing of the endometrial carcinoma, but few other factors can also be taken into view. The one is obesity. Those who are having their increased BMI are prone to developing endometrial carcinoma. Diabetic patients, well, diabetes is a condition in which patient is exposed to all sort of abnormalities, but especially endometrial cancer. Hypertension is another cause, and those who are with the low parity. Low parity mean those who are having children and they do not want to go or to further go onto the family way. So there is a great chance of developing endometrial carcinoma in those females as well. So these are the sign and symptoms and presentation which you will see the patient with the endometrial carcinoma present with. So be careful when the patient complain of all these things. Always advise the ultrasound scan, especially transabdominal scan and transvaginal scan, and on the basis of all these investigation you can pick endometrial carcinoma. On the ultrasound imaging, endometrial carcinoma will present in multiple presentations. It will show multiple presentation. The one is endometrial thickening. So whenever there is thickened endometrium, there is likely possibility of developing endometrial carcinoma. The second thing is there will be poor definition of endometrio-myometrial interface. Whenever there is poor definition of endometrio-myometrial interface, you may suspect endometrial cancer. The third thing is heterogeneous endometrium. Whenever there is heterogeneity of the endometrium, you bump into endometrial heterogeneity, you may consider there may likely be endometrial carcinoma. The third thing is there will be a cystic degenerative changes. Normally, cystic degenerative changes can be seen in atrophy, in endometrial hyperplasia, and in polyps, but it is also likely that there may be any malignant process. So endometrial cancer can also be seen with cystic degenerative changes. Uterus will also be enlarged. There may be myometrial invasion. Endometrium will penetrate in the myometrium, and you will see that this is invasion of the myometrium. So these are the features which you can easily appreciate on the ultrasonography. Beside this, Doppler play an important role for distinguishing between the hypervascular cancer and avascular cancer. It would not be typically avascular cancer, but on the Doppler imaging you cannot easily detect all these subtle vascularity. But normally endometrial carcinoma happens to be hypervascular. Whenever you put Doppler signal on, you will see there will be hypervascularity. So these are the features which you can appreciate sometime on the transabdominal imaging. When you are performing transabdominal imaging and you come across any subtle findings, or you feel that there is atypical changes which is not presenting the normal endometrium, so go for the transvaginal. On the transvaginal scan, you can clearly visualize all these changes. You can see the myometrial invasion, you can see myometrial endometrial interface, which will be no longer maintained. And beside this, if there is any other process like cystic degenerative changes, you can also appreciate that. Or within the endometrium, if there is any mass developing, you can also appreciate all these features. So how it will appear on the ultrasound imaging, this is the important. And today we have certain slides available with us to help you to understand endometrial carcinoma. So there are multiple presentation. It happens to be hypoechoic, hyperechoic, heterogeneous, so multiple varieties there. So let's start watching these images, and I'm sure you will be able to understand and pick endometrial carcinoma on the ultrasound imaging. On this ultrasound image, it is a transabdominal scan and uterus is clearly visible, but here you can appreciate an heterogeneous large endometrial mass compressing the myometrium. So this is actually endometrial heterogeneous large mass, and this is endometrial carcinoma. Endometrial carcinoma happens to be in multiple shapes, or sometime it will appear hypoechoic, or it may be hyperechoic, or sometime it may appear heterogeneous. What you need to confirm is you have to measure the size of it in all three dimensions, and beside this you have to look for any compression on the endometrial or myometrial interface, and if it is beyond that limit, so look for the compression effects on the myometrium. Beside this, you have to focus on the contour of the entire uterine body. Is there any distortions taken place due to endometrial carcinoma or not? At the end, it is important to put the Doppler signals on and look for the vascularity. Many a time it would be hypervascular. So on your report, you mention about the endometrial thickening, endometrial mass lesion, its contour, and its effects, compression effects on the either endometrio-myometrial interface, or if it is beyond that limit, so mention about the compression of the myometrium. Beside this, also mention that the uterine contour is maintained, fundal body is right, cervical region is not distorted. On this transvaginal scan, you can appreciate an enlarged uterus. First of all, always look for the contour of the uterus, whether it is enlarged or not, and try to focus on its fundal part, uterine segment, and the cervical region. Here on this scan, you can appreciate that the fundus and the uterine body is enlarged. So there is no longer maintenance of the differentiation between the body and the fundal region. Here on this transvaginal scan, you can appreciate a well-defined large echogenic mass which is obliterating endometrial cavity and penetrating within the myometrial interface. So there is no longer maintenance of endometrio-myometrial interface. There is no clearly or well-defined endometrial cavity because this large mass has obscured the endometrial cavity. So now focus on the mass. This mass has round margins. Inside the mass, slightly or mildly cystic degenerative changes can also be seen. However, parenchyma is not heterogeneous, not much heterogeneous. Rather, you can call it as a homogeneous parenchymal changes. So on your report, mention the size of the mass, echogenicity of the mass, and it's worth mentioning that the mass has obliterated the endometrial cavity and penetrating within the myometrium. So far the size of the uterus is concerned, it is enlarged because of the endometrial tumor. This endometrial tumor is neoplastic tumor, it is carcinomatous tumor, it will appear in this form as well. This is another example of echogenic mass. This is a transvaginal scan. Uterine body is obliterated, endometrial cavity is obliterated, and large echogenic mass can be seen within the endometrial cavity. Look for this mass has already penetrated within the myometrial area. As far the outline of the uterus is concerned, it is slightly irregular. Contour of the uterus is slightly irregular. However, cervical region is preserved. There is no cervical changes. So what you need to do is you have to measure this. Here on this image you can see caliper and it's showing its measurement. So mention the measurement, and so for the mass outline is concerned, you have to mention that whether these margins are smooth, regular or irregular. It is slightly irregular, heterogeneous mass, but predominantly echogenic. Put the Doppler signal on it. If there is vascularity, mention that this mass is hypervascular, or you can also label it there is no vascularity within it, and advise further radiological imaging, especially histopathology. And this image and this patient was confirmed on the histopathology as endometrial carcinoma. So this is also a presentation of endometrial cancer. Here on this transvaginal scan, you can appreciate that the uterus is enlarged, and within the uterine cavity you can appreciate a well-defined homogeneously echogenic mass, a round mass. Take the measurement of this mass. One of the important worth noting point is small part of this endometrial mass penetrating within the myometrial parenchyma. Although myometrial parenchyma is reduced, it is shrunken because of distended endometrial cavity due to mass. This is endometrial carcinoma. However, its margins are regular and smooth apart from this small indentation and penetration, this small projection within the myometrial cavity, within the myometrial parenchyma. So put the Doppler signals on it. If there is any vascularity, so you have to mention this on your report whether it is vascular or not. Most often it happens to be vascular because of the spiral arteries. Spiral arteries are supplying endometrium and endometrial mass. So usually endometrial cancer happens to be hypervascular. Write on your report patient scan with a transvaginal probe, and large mass can be seen penetrating endometrial cavity, obliterating endometrial cavity, penetrating within the myometrium, measuring blah blah, whatever the measurement is, you must give the measurement. There is no central or peripheral cystic degenerative changes. There is no calcification seen in it. A small penetration, a portion of the tumor being penetrated in the myometrial parenchyma. This is one of the reason that it may cause extension into the perimetrial tissues. So before it's happening, it's better to take this mass out, because it is highly aggressive mass and it will involve the entire perimetrial tissues. So this is another example of the endometrial carcinoma. This is another example of endometrial carcinoma. On this image, this is transvaginal scan, and on this transvaginal scan you can appreciate a hypervascular mass. Actually, this hypervascular mass is invading endometrial cavity. So within the endometrial cavity, this large mass, predominantly hypoechoic large mass, you have to give the measurement, whatever the measurement is, and also mention there is no cystic degenerative changes in it, there is no calcification within it. Margins of the mass are smooth, although not very well defined. These are ill-defined margins because the interface between the mass and the myometrium cannot be easily distinguished. So it means this mass is also penetrating the myometrial parenchyma. Give your measurement. Mention that uterus is enlarged due to endometrial hypoechoic hypervascular mass. This may likely be cancer. Further higher imaging is suggested to rule out any malignant potential. Best is to advise histopathology. Best is to advise surgical intervention, because whether in terms of total hysterectomy, or they might take the biopsy for that through the curate, whatever the procedure they want to adopt. But normally this is hypervascular malignant looking mass, likely endometrial cancer. On this transvaginal scan, you can appreciate an ill-defined, ill-marginated, atypical lesion. These three terms I have used here because I cannot appreciate its outline, so that's why it is ill-marginated. Ill-defined, I cannot easily appreciate where the myometrium is and where the endometrium is, so still all ambiguous, so it is ill-defined as well. So ill-marginated, ill-defined, and second is it's a polypoid lesion. It looked like a polyp arising from somewhere from the endometrial cavity. Endometrial cavity is obliterated, myometrial parenchyma is penetrated. There are three characteristics so far the echogenicity is concerned. You can find patchy area of hypoequic patchy areas. There are some hyperequic areas as well, and heterogeneous areas as well. So from the point of view of ultrasound echogenicity, still this is a mixture mass. You cannot easily, or you cannot definitely comment whether it falls in the category of completely hypoequic or completely hyperequic or totally heterogeneous, but to some extent we can use the word heterogeneous. So this is heterogeneous mass with patchy area of hypoequic and hyperequic with ill margins. Uterus is enlarged, uterus is distended, and this mass shows centrally cystic degenerative changes. So mention the size of the mass, document that uterus is enlarged, its contour is obliterated, so this shows malignant potential. Further higher imaging is suggested to rule out any confirmed malignant diagnosis. So always be careful when you come across any atypical lesion which does not fall in any radiological patterns. So always raise your suspicion, because malignancy is usually appears in such forms when there is no particular radiological patterns. So this mention and refer this to the gynae department for further workup, and refer for the higher radiological imaging to confirm the malignant potential. All kind of cancers are needed to be classified into staging. There are different stages for the different type of carcinomas, for the different type of cancers. So far the endometrial cancer is concerned, endometrial cancer has 4 stages: stage 1, stage 2, stage 3, and stage 4. So let's talk about stage 1. Stage 1 has 2 categories, stage 1A and stage 1B. What happens in stage 1A? In stage 1A, endometrial cancer remain confined up to endometrium, or it will progress halfway in the myometrium. So that will be called as stage 1A. In the stage 1B, endometrial carcinoma will be within the myometrium up to halfway or more than halfway. That will be called as stage 1B. What happens in the stage 2? In the stage 2, the carcinoma, the cancer will remain confined within the uterus, but it will involve the connective tissue of the cervix. If the cervix is involved, that will be considered as stage 2 endometrial carcinoma. In stage 3 endometrial carcinoma, the endometrial carcinoma will comes out of the out of the uterus and will involve the pelvic region, nearby the pelvic region. If the nearby or surrounding pelvic area is involved, that is called as stage 3. In stage 4, what happens? This endometrial carcinoma penetrates within the urinary bladder, it penetrates within the rectum, it penetrates in the groin, in the lymph node, or nearby surrounding tissues. So that would be called as stage 4. So these are the 4 stages of the endometrial carcinoma. And for better understanding, there are 2 criteria. You can also distinguish these stages on transvaginal scan and on MRI, but it is best to have contrast enhanced MRI, which is used for the endometrial carcinoma staging. This scan shows endometrial sarcoma. This is transvaginal scan and it shows a heterogeneous endometrial mass nearly measuring 27 in its thickness. Here in the endometrial cavity, you can see that this is arising from the endometrial cavity, but this is a sarcoma. As we have already discussed about the leiomyosarcoma, because that is from the myometrial tissues, and usually this myometrial sarcoma happens to be arising from the endometrio-myometrial interface. That is the best place for the origin of the endometrial sarcoma. There are multiple types of the endometrial sarcomas. The one is called as carcinosarcoma. So this is the example of carcinosarcoma, which was confirmed on the radiological imaging. But again, I would mention here, there is no clearly distinguishing features on the basis of the ultrasonography to confirm the carcinoma from the sarcoma and from the other types of the malignant tissues. But to some extent, ultrasounds ultrasounds point out certain features which gives rise to suspicious of malignant potential. So keeping that in view, whenever you come across any atypical lesion, when you come across any atypical pattern, radiological pattern, always raise your suspicion, send for the further workup and also for the higher imaging. After higher imaging, they will conclude whether this malignant mass, this mass is malignant or this mass is benign. On the grounds of the ultrasonic imaging, sometimes you cannot reliably include whether, you cannot reliably say whether this is malignant or not, but in certain cases there are certain features, radiological appearances. On the ground of these radiological appearances, you can raise your suspicions that this looks like a malignant or aggressive mass. So far this slide is concerned, this is a best example of endometriocarcinosarcoma. So mention and refer the patient for further radiological imaging. Yes, friend, endometrial cancer has been discussed at length. I have discussed about the signs and symptoms and clinical features of the endometrial carcinoma. Besides this, I have also mentioned how it will appear on the ultrasound imaging, how you will able to pick the points of thickened endometrium if there is indefinite, poorly defined endometrio-myometrial interface, if there is enlarged uterus, if there is heterogeneous endometrial echogenicity. So these are all the points which will help you to understand the endometrial carcinoma. Beside this, I have also explained what's the difference between the endometrial carcinoma and endometrial sarcoma. And one of the very important point which I have clarified here, that how you will stage the endometrial cancer. Endometrial cancer stage 1, stage 2, stage 3, stage 4. I think these can be easily picked on the transvaginal scan and on MRI. While you are performing transvaginal scan, please pay attention to all these stages. Look for the endometrium, look for the endometrio-myometrial interface, look for if it is penetrated within the myometrium. So on the basis of all these features, you will be able to identify the staging of the endometrial carcinoma. Besides this, I have also mentioned about the sarcoma and endometrial carcinoma. Although on the ultrasound imaging, you cannot definitely say whether this is endometrial carcinoma or this is endometrial sarcoma, but to some extent you will be able to pick certain and subtle points. So this was all about the endometrial cancer. I'm sure this video would be worth watching. Keep watching my videos, keep sharing with others with some other new points. We'll see each other. Till then, take great care of yourself. See you then. Bye bye.